Good morning.
Good morning.
I'm not sure if you are going to put up the introductory slides. I have printed copies, so if they've changed recently. Okay, good. Thanks.
We do have a quorum.
Okay, so should we get started? All right, welcome everyone. I hope you all are doing well and that you had a good holiday season, had a chance for some rest and peace. So take care of the business part. This meeting is being held virtually, hosted by the Utah Department of Health and Human Services and the Center for Medical Cannabis, based in Salt Lake City, Utah. Public notice of this meeting was provided as required and is posted on the Utah's public notice website. In compliance with Utah's open meetings law, this meeting is being recorded and the recording will be posted to the public notice website within 3 days following this meeting. Written minutes will also be prepared for this meeting. Approved minutes will be posted to the public notice website within 3 days after board approval. Okay, just a reminder, the purpose of this board is to review the available research, literature, and assist the Utah Department of Health and Human Services and Center for Medical Cannabis in their efforts to provide useful treatment recommendations to qualified medical providers regarding the use of cannabis and cannabinoid products for treatment of certain medical conditions identified as qualified medical conditions. And the board members are listed here. We have a quorum. Do you want me to read off who's here? In which case I'll need some help.
I can help you with that, Dr. Carlson, if you need some help.
Well, yeah, I can't see everyone that's here.
Oh, sure. Yeah. Yeah. So obviously Dr. Carlson is here. Dr. McKiff is present. Dr. Fine is present. Dr. Sender, are you present?
No, he couldn't make it today.
Yeah, I think Brian couldn't make it.
Yeah, it's out. I did see Dr. Norris here. Dr. Moss, is he joined yet?
Yep. Mike is someone I can see. Hi, Mike.
Yeah. And then Misty Smith did excuse herself. She's traveling today.
Okay, and Mike, I know that you need to leave early, so we rearranged the agenda just to make sure you can be up front. before
Okay,
you
thank
leave.
you. I was able to move some things around and juggling and being on inpatient addiction consults today and doing all this stuff too. So I should be fine
Okay,
either way.
well, thank you. We'll see if the agenda, I can't remember. I'm not sure if the agenda was reworked. We'll find out, but
Yes, it was.
sorry, Sarah, say that again.
Yes, it was. So he's right after the approval of the minutes. So
Great, okay. Well, I think we finished with this slide. So just a reminder about the public comment period, which will occur once we've completed the agenda items. And comments need to be limited to 2 minutes per person, and we will take comments one right after another, answering or responding after all of the comments are heard. As a courtesy to everyone participating in this meeting, please place your speaker on mute unless you are speaking to the group. Board motions and votes will be recorded in the minutes. We will now turn our attention to the agenda. Okay, so welcome everyone. Can we see the minutes, and let's take a minute to glance over and see if there are any revisions needed.
Dr. Carlson, just one thing I saw on the first page. Sarah, could you go up there? If I could just suggest that the board may want to keep going up. It states that this meeting was held in person and virtually. I didn't catch this before. We probably want to delete in person.
Yeah, good.
Because it was just completely virtual. So that
I
may
wonder
be
if
just a
that's-
small thing.
I wonder if that got onto other minutes and if that needs to be revised as well.
Yeah.
Can take a look at that. Okay. Thank you, Rich. Are there any other suggestions, or do you need a little more time, board members?
I motion to approve the minutes.
Thanks, Mike.
I'll second that.
Okay, all in favor of approval, say aye or raise your hand.
Aye.
Hopefully someone's counting. All opposed?
Nope.
Okay, I think there were no opposed, although I cannot see everyone. Okay. So you are at the top, Mike, so and thank you as always for your expertise and participation here.
Please unmute, Mike.
Oops, there we go. I think that some of the boards want me to talk about for a while about what about poison centers and what we hear about cannabis. I'm happy to share my slides and drive, or if Sarah, you want to, it's fine by me too. If you got it going, then that's good enough for me. My slides have not changed since I sent them to you, so that's good enough.
Are you sure? I just made you co-host so that you could if you want to. You choose.
I'll do it that way. I can go back and forth and things.
Okay.
So let me pull mine up. Everyone's seeing my slides okay?
Yep, I
Yes.
can see them.
Okay. Yeah, so what this is I'm going to talk about what do poison centers know about cannabis exposures, what trends have we seen, and how might that influence any actions the board could take or wish to take related to medical cannabis in Utah. So I am medical director of the Poison Center, which is where I spend most of my time. Though today I'm on inpatient addiction consults at the university. Nothing to disclose here. If you guys remember nothing else, not that this is a complicated topic by any means, but when there is more access to cannabis, there are more exposures. That shouldn't be anything too exciting. It happens with anything, right? From household cleaners and chemicals to over-the-counter ibuprofen to prescription medications to everything else. If there's more of it out there in the world, then more people are accidentally going to get into it. I keep using this term exposure. It's a term we use in the Poison Center world because someone may have been exposed. We don't know if they ingested it, inhaled it, put it on their skin, or otherwise. We don't know how much they got. And so we say exposures. And I use cannabis to include all derivatives of cannabis plants, be they edibles or vape or flower or whatever. So there's just some terminology there at the front. I'm mostly talking about people who experience some sort of adverse effect from taking too much cannabis, and then they either call the Poison Center or they go to an emergency room or call their doctor because they're not having a good time. And so what that usually means for us is in adults, you've got an adult who is too high and having an anxiety or panic attack. Unfortunately, in kids, it's a little different. They tend to be very sleepy or sedated, or they can't walk straight, or can't even be woken up. The good thing overall is that really serious or dangerous outcomes are exceedingly rare. Death, probably almost never, with a few very minor exceptions that don't apply to the vast majority of people, and a few other serious outcomes that are pretty uncommon. What should anyone do about it? Recommend that you store any medical cannabis product or recreational product the same you would any other prescription medication, in a container that is not appealing to children, that is resistant to children, and that is locked up and away from their reach. And that we make sure that everyone knows what is in one of these products is cannabis and is not food or candy. So I'm just going to walk you through a whole series of studies dating back a little bit earlier to stuff that's hot off the press like a week ago as far as cannabis exposures. So here's Colorado. This is pretty basic. This is not a huge number of patients, but this is when Colorado started a medical cannabis program. And they were seeing, they all of a sudden noticed they had a bunch of kids showing up to their ER in Denver who had ingested cannabis. And they were like, what in the world is going on? Were we seeing this before and we just weren't paying attention? Well, they looked at a prior period, prior to cannabis legalization for 4 years, and they had 0 cannabis exposures in kids coming to the ER. Well, there were plenty of over-the-counter things like Benadryl or Tylenol or things like that. And then they had 14 that all of a sudden popped up in the period immediately after medical cannabis came around. Again, this isn't looking at bad things. Most of these kids do all right, but some of them do need to be admitted to the hospital. We'll talk more about that. We can look at a similar thing, and here's the state of Michigan. Michigan got medical cannabis in 2008, and they legalized recreational cannabis for adults in 2018. And they looked at the number of pediatric exposures by year. And they break it down into edible versus non-edible, because of course, little kids tend to get into things they can eat. And all things pediatric and all things Poison Center, we have a cluster of the 2-year-olds, right? The little toddlers who explore their environment and put lots of things in their mouths. And then we have adolescents who are much more in the just using things recreationally and sometimes suicide attempts. So you can see it did start to have a little bit of an increase year over year, and then a real big takeoff as recreational cannabis. You can see it even started before they had recreational cannabis. That probably reflects just the growing cannabis market across the country, and perhaps more and more of this out there, be it legal or illegal, from various sources. This is data from all poison centers in the United States. So every poison center, we have the Utah Poison Control Center. We serve all of Utah and only Utah. There are 55 poison centers across the country that serve various combinations of states and things. And all of that data, every time someone calls a poison center, it gets logged in and goes into a national database that is used for all the sort of surveillance for all sorts of things. And so this is looking at all poison centers and all types of cannabis exposures and all ages over a couple-year period. And this is showing what's happened since 2017 to 2019. And you can see the top blue dashed line is total cannabis exposures. You can see the solid blue line is plant material. So weed, as we might call it, or flower, has declined a little bit. And then you can see this, I don't even know what color this is, medium blue, gray, green, something. is edibles, and this has grown the most substantially. And then we have a little bit in vapes and concentrates that have gone up as well. And these are all under the orange line of derived products that have been processed from flower. So all those have been increasing substantially, where they were almost not there a few years ago. Some of this also goes to coding and the way we assign labels to things, but that's not the most important part of this. What about our friends in Canada? They've been doing things a bit differently. And they looked at 3 periods here. I forget which province this one was specifically. I'd have to pull up the paper there that I have at the bottom to double check. And they have, before there's recreational cannabis, they have a first period where cannabis was legal, but edibles were not yet legal. And then period 2 where edibles were legal. And you can see that edibles are these bars here. And that as soon as edibles became legal, there was a big jump in the number of pediatric visits for edible exposures, it turns out. What do you know? But cannabis exposures overall were increasing along the way before that for other ones. Massachusetts, I think I tried to focus on the medical data as much as possible, since that's what we have here in Utah. And here's Massachusetts. And again, this is mostly looking at kids. This is looking at kids. Most of these papers are looking at kids. And they looked at the number of before medical marijuana legalization in the dark bars, and then after in the lighter bars. You can see plant material, not too much of a change. For edibles, this is this top right chart, and you can see they didn't have any before. And so there's a big increase because there's almost nothing before that. Concentrates, again, there wasn't anything before there was medical, and then some other defined things there. So these aren't huge numbers, right? We're talking about, cases in the, hundreds or thousands, but just showing that both medical and recreational cannabis can lead to increased exposures in people who aren't supposed to be taking them and causing them problems. This is another way to slice and dice US poison center data. And we might wonder, well, I talked a lot about kids. What about everybody else? Is this just a problem with pediatrics? No, here's adults over 50. And what happens with adults over 50? You can see this big blue line is the spike of synthetic cannabinoids and spice, where poison centers got a lot of calls about spice back in 2015. We still have them, but not quite as common. The green is dried plant or flower. And then these bars that start ticking off here is also part of like how we started defining the different codes for it in the database. But you can see this red line, edibles, just went and just skyrocketed there. And as did these others. This purple is CBD, not as important. And then this one is concentrates. Here is the darker red line. And you can see even in older adults, we have more people exposed to these who are calling the poison center for one reason or another, usually because they took too much and they feel bad. And then last but not least, this is hot off the press about a week or two ago in pediatrics. And this is more poison center data. And what they did is they also adjusted this per total cases reported. So this isn't just raw cases, this is what most of the data from those other charts were, but this is adjusted. So this is adjusted for all the kids who are getting into some cough syrup, all the kids who are getting into the bleach under the sink and everything else. And so as a proportion of all pediatric cases reported to poison centers, what's going on? And this is across the country. And you can see from 2017 to 2021, we've had an enormous increase from 0.2 to 3.6. So more than a 10-fold increase in cannabis exposures across the country as a proportion of other poison center cases. So National Poison Data System, that is all of the database for all the poison centers across the country. And then you might ask, well, that's everybody else. What about Utah? Because Utah is different in lots of ways. So how are we different? Turns out we're not very different in this case. So this is our internal data. So this is not published. I have some internal dashboards and things I use to create this. We create a log of cases. We get 45,000 new cases every single year in Utah from a wide variety of things. And this is specifically cannabis exposures. And again, we're not differentiating recreational versus medical. We don't know what state anyone got any of this from. People aren't always happy to share that information with us. And it's not always the most important thing when we're just trying to take care of an individual patient. But you can see that we had kind of a low level of cannabis exposures, around 100 a year for a long time. Our data goes back to about 2000. And it's started taking off around 2015 until we reach where we are currently, 2022, where we've hit our new high up to 700. So a 7-fold increase from the baseline of where we were years ago. You might ask, well, does this coincide with anything? I've listed here the various states that are around us in the West, and when brought both medical and recreational cannabis to market. These dates, I tried my best to put the date when it was actually available to be purchased, because there's dates when a law passes or a vote goes through and when a law is enacted versus when it's the stores and the dispensaries are actually open. So to the best of my ability, these are the dates when you could go acquire it yourself. And you can see this 2015 is kind of the inflection point, though we didn't really see the big increase to about 2017. And what's happening all around that time is legalization of recreational cannabis for adults throughout Colorado and then the Pacific coast. And as best as I could say, right, I can't track this to any one state. I don't know where anyone got it, but we all know that all those states had excess cannabis and it flows over to us all the time. And you can see medical cannabis didn't really seem to have a big jump for anything for however long it was there. And Utah, we didn't really have this till just a few years ago when things were in action, that we were already well on our way to an increase in cases. And I don't know that our medical cannabis program here in Utah is necessarily the cause of this continued increase after 2020. We added states like Nevada and Arizona. West Wendover didn't get its first dispensary until 2019, December 2019. So the easy access to the greater Salt Lake area by driving over to Wendover didn't come until a little bit later. So I don't know an exact reason, but I can see as more cannabis is available in our half of the country, we get more calls about it. Here's the adverse effects part of this. So in adults, as everyone may or may not be familiar with for personal reasons or observing others they've come into contact with or talking with patients, that many people experience anxiety and paranoia. Now, this can be part of just usual cannabis use, but people get way too high sometimes. You may have seen the video that goes around of a police officer who stole some cannabis from the evidence lockup. And he and his wife took it, and then he is so high that he calls 911 and tells them that he thinks they're dead because they were so anxious and paranoid about being high, and they're asking for help. And in fact, they are completely fine, but the anxiety and their anxiety about being anxious kind of feeds back on itself, and they're incredibly anxious and paranoid, usually not suffering any ill effects from a medical standpoint or anything life-threatening. But people do bring themselves into emergency rooms, mostly because they're having a panic attack, even though they're fine, and you have to tell them you are actually fine. If we have to, we give them a little bit of sedative.
I'm just curious, Mike, was that a Utah incident or is that?
No, I
something
have to
on the
remember this.
airwaves?
This is one of those like things that gets recycled on
Okay,
YouTube
got
and
it.
on the internet and whatever. I think it may have been California, but that's just a guess out there. And if you Googled, police officer 911 edible call or something, you listen to this guy's 911 call where he, steals the cannabis, takes it, and then is asking for 911 to come help him because of how anxious he is from it. And I want to make fun of people, but this is what happens. And the good thing is these people are usually pretty okay, and they're pretty okay, and it's not so bad, right? Synthetic cannabinoids are a different beast. Edibles are a big piece of this too. I didn't show that in some of these here, but edibles represent a disproportionate number of these exposures compared to the amount of things sold. I didn't show that paper. There's a nice one from Colorado where they look at amount sold in the state of edibles versus flower versus vapes and things. And then the number of visits to an emergency room based on those same things. And edibles have almost a complete flip-flop. When they represented a small portion of retail sales, they were the number one for visits to the hospital. And why is that? Because it takes an hour or two or more for it to kick in. People aren't used to it. They don't know how much the dose is going to be. They're not sure of the serving size, and they'll eat, an entire cookie, or they'll eat 5 pieces of chocolate or 5 gummies when in fact they should have had 1 or half of one. And so they get an enormous dose, or they don't feel anything after an hour and then they take more. And by the time it all kicks in, it's way too much. So edibles is where the problem is. Makes sense for kids, right? Of why edibles would be the problem. Kids like to eat stuff, and a lot of these things are made to be very palatable, right? They're made to be sweet or chocolatey or otherwise. And depending on how they're labeled and how they're stored, it can be easy for kids to do it. Bizarrely enough, kids sometimes do get into flour and eat flower, which sounds gross to me, but kids, I'm never ceased to be amazed by what children will or will not eat at the poison center and the things they decide to consume. The bad thing for kids is a lot of times people don't know, right? The kid can't tell you they ate an edible. And so some caregiver finds them not acting right and stumbling around, and they get brought into the ER, and someone doesn't know what's going on, and they get spinal taps or MRIs, or they have to go to the ICU. And sometimes they're not at a children's hospital, so they have to get transferred to a children's hospital. And as part of that, they're so sleepy, they get intubated and have to be on a ventilator. And then very rarely we see some things like a seizure that happens. We think of cannabis as being used to treat seizures, but in some cases it has been associated with causing seizures in kids. So these are big doses that these kids get, and that's pretty rare. This is like a less than 1% sort of thing. But when we have hundreds of these exposures every year, that means every year we're going to have a kid who gets pretty sick from it, just by the numbers. What does all that mean? Like I said at the beginning, more cannabis available simply means more cannabis exposures. We at the Poison Center tend to be fairly agnostic towards all of these medications and drugs, prescription, otherwise, whatever it is, we know if there's more of it out there, we're going to get called about it. And it'd be nice if these kids and adults and everyone else, patients, non-patients, and family members didn't accidentally get into things. Is anyone dying from this? No. Edibles are the biggest problem. Like I said, seizures do occur, but it's pretty rare in children. Fortunately, reports in adults are the ones I know of a potential death associated with it are people who were so incredibly sick otherwise, it's really hard to tease apart what was the cannabis and what was all of their underlying comorbidities, but certainly don't have people dropping dead from these by any means. How much is medical cannabis in Utah contributing to this in Utah? I don't know. We were trying to look at that at the Poison Center to ask that question. We just didn't really get anywhere with it. It's hard for people to know. We're often getting calls from doctors, and the doctors don't know where the patient got it. The patients don't want to say where they got their cannabis from, as they're afraid from legal repercussions and things like that. They're already feeling anxious or paranoid, or they're afraid of their kid getting in trouble. So I don't know where the cannabis is coming from. I don't suspect that it's all Utah medical cannabis, because this has been increasing for a long time before medical cannabis was available in Utah. So what should we do about it? Prevention is part of what we do, right? I take care of people who have been poisoned, but I'd like for them to not get poisoned in the first place. So this is all pretty straightforward stuff, right? I would recommend to treat it like any other medication. So that would mean don't store it next to the candy and snacks in the pantry. Don't have it around kids. Let them know if they're old enough that they shouldn't get this and this is medication. It should be labeled as cannabis so adults don't open this up and see some bag of gummies and decide to eat them. It should be labeled as a medication, and it should be clear that this is cannabis. For edibles, the dose should be quite clear, and there should be instructions about it of, hey, take only one of these or take only half of them. Don't sit back and just eat the whole bag of something. Labels should not be attractive to kids, and they shouldn't confuse adults either. So it's not just about kids, but adults also need to not be confused by something there. Child safe packaging, just like other things. We have the Poison Packaging Prevention Act from the 70s, right? We have these tamper resistant little bottles that all the pills come in. Something like that would be reasonable for cannabis too. I suppose this is my disclosure. I helped write this position statement for the American College of Medical Toxicology, and we made a series of recommendations for preventing cannabis exposures. It was geared towards children, but it applies to everyone, and this sort of sums it up here on this slide. Everyone has seen this photo from DEA, right? This is not Utah medical cannabis products, but here are a bunch of candies seized from another state, and instead of Musketeers, you have the 3 Rosteteers. Instead of Kit Kat, you've got Keef Kat, the Butterfinger, Trichome, Crumb Crunch, all sorts of things like that. This is not the way to sell cannabis and make it look like candy. This is only going to lead to people getting themselves in trouble and accidentally eating these. You may have heard about the kids who got a Nerds candy rope from the food donation from the food bank, and someone donated a cannabis Nerds rope, and these poor kids ate it, and it had like 500 milligrams of THC in a cannabis Nerds rope, and the labeling was not great. It looks like Nerds candy, but if you look closely, it did have the THC symbol on there. But they got it from a food pantry, and who knows who donated that. I'm assuming someone donated that accidentally and did not mean to give away 500 milligrams of THC. So that is bad. Again, my take home points. I think what we need is we have many of these in Utah. I think they could potentially be more strict, right? We get our prescription pills in a little amber bottle with a white cap. It doesn't look the least bit interesting. We know that that's a medication bottle and we keep it away. It has a child resistant, not child proof, nothing's child proof, cap on it. And that would be a great way to reduce accidental cannabis exposures. And we should let people know that they should treat this like a medication and tell people that they should treat it that same way. We do have laws in place in the Medical Cannabis Act that things should not be labeled to look like food or candy or to be attractive to children. So we do have that in our statute here. There's a bunch of papers of all those studies if anyone's interested, and I'd be happy to go back and show you any more of those or answer any other questions people have.
Mike, thank you. And this is actually a great lead into the next topic on our agenda, which is about dosage. But before we go there, do we have time for some questions from the board about the presentation?
A quick question, Mike. You showed on your graph an uptick, not surprisingly, since 2018 for cannabidiol CBD, because it's now ubiquitous, and it would be surprising if there wasn't. What type of adverse effects are you guys seeing or getting reported in the Poison Control Center or ERs? And are these documented? Are these self-reports that this was CBD ingestion, or is there some form of confirmation? Because we all know that it may or may not be as labeled.
Yeah, great. You basically answered your own question. They have, yeah, what is this that this person got into, right? Did they buy a CBD product? Utah was one of the states where CBD actually had synthetic cannabinoids in it, and the Poison Center was part of a little investigation there. That was like 5 years ago, before CBD became more ubiquitous, right? With some of the changes to the Farm Bill and things like that. But we don't know, and now we live in the age of Delta 8. 5 years ago, it was spice getting put into CBD. Now people aren't recognizing if they're actually getting CBD or it's CBD plus Delta 8 and things like that. Are they telling the truth? Do they know the difference? Where are they getting? The good thing is people getting into CBD are doing totally fine. I think it's people getting too much or their kid got some, but good thing about cannabidiol is I expect almost nothing. About the only thing we know is from the trials for Epidiolex, the pediatric seizure medication that CBD is, that some of those kids have some excess sedation, but it is not causing the same sort of problem. But more of it's out there. People are taking it. They take too much. They're not sure. They wonder if they can combine it with their medications. And then there's definitely some of these where people aren't sure what they actually got, and did they get something that actually contains something more psychoactive like Delta 8 or even Delta 9.
Mike, what is the explanation for the difference in reaction between kids and adults? What's the explanation for the sedation response?
Yeah, it's we don't really know why that is. Some of it is like, well, maybe the dose is just so high that these kids push through the anxiety, right? Everyone knows of the patient, they're stoned and they're on the couch and they can't move, you know. That happens with adults, that you're locked into the couch. So is that what happens to the kids? Is they just get all the way past through this anxiety? But I don't have these 2-year-olds coming in like anxious and freaking out at all either. So that's about the best explanation I've ever read or found, is we don't know. Or maybe it's these kids are getting such a big dose compared to their body weight, you know, compared to adults. But not a great explanation as far as the pharmacology or the physiology. I don't know the answer.
I mean, it's running into, I mean, the kids have different responses and presentations when there's anxiety and overwhelming anxiety. So
yeah, and the common theme is like these kids are unresponsive. If not, they're like afraid and like just not talking to someone, but they're like brought in because they're not responding and they're falling over walking. And then, you know, the 2 or 18 months they can hardly walk to begin with. But
oxygenation wise, from my understanding, they're not necessarily all of them, you know, desatting. It truly seems like a anxiety response.
Yeah, I think, I don't know if I could call it anxiety. These kids, they're definitely just sedated. They don't have respiratory depression like opioids for sure. I suspect that a lot of these kids that do end up intubated are for transfer reasons of someone doesn't know what's going on because no one tells them and they don't have a urine drug screen back to find out that this kid has THC in their urine. And of course, if you have a kid who has a seizure and then they're not waking up, they get intubated. Whether or not they had apnea, right? Did they stop breathing? A handful of those are described, but like I said, this is in this like less than 1% of these cases. The majority of these kids, some of them we keep at home. If they got a small bite of something, we'll have them stay at home and we'll call them back. And if they get symptomatic, send them into the ER. And when they're in the ER, most of the time they sit there for a little bit until they relax and then they're able to go home and they're not too bad off. So we have plenty of kids who, go to the ER just to get watched for a little bit and then back home. Some that get admitted, most are fine. And pretty rare for these kids to end up in the ICU. Sometimes they end up in the ICU out of an abundance of caution. And so that's why you'll see some of these studies that list the number of kids admitted to ICU can be big, probably because people didn't know what to do and they just put them in the ICU just to be safe, rather than they really truly needed ICU level of care.
Are there questions? Oh,
Yeah.
go ahead. Sorry.
Mike, I really appreciate your presentation. I thought that was excellent. And I like how you finished, because when you look at that data, it's not intended to scare us all. I think, pardon the analogy, but I think about before cars were invented, we didn't have many pedestrian accidents. But once cars were invented, we started getting more pedestrian accidents, just exposures went up. And it was up to us to develop regulations, traffic laws, safety, education, standards, in order to prevent, more bad outcome, not get rid of the cars. And so I think, pardon the analogy, but I think that's where we are now. This isn't going away. We don't want it to, because we have some benefits from it, but it is up to us to finish on that note of how do we make this safe and useful in the future. And I like how you finished with and we could go on with that. What other regulations should we do to make it safe? And prevention is key. So thanks again.
I have, touching on that, are there states a little farther ahead than Utah that have maybe you showed a slide that showed the total exposures for the country. Are there states that deviate, that maybe for one reason or another, the lines aren't a steep incline like the average across all states?
I don't know that anyone has broken down that comparison state by state. Other things that have been done that didn't show. There's tons of stuff out here. There's a lot of papers, because every new state that does this, someone writes a paper in that state about their state, and it's over a different time period with a different law. And then as new states come online, they now exist in a different world of cannabis than where we were 5 or 10 or 20 years ago. So hard to compare. I don't know of anyone who has somehow magically been successful. And I think Utah is a good example, right? We had no legal cannabis for a long time, yet cannabis exposures were going up because it's coming in from the West Coast, it's coming in from Colorado. More people are comfortable with the idea of cannabis and more likely to use it. So even if we still had no medical cannabis in Utah, right, we had already had a 5-fold increase in cannabis exposures in our state before we had any form of legal cannabis.
Yeah. I was just curious on that kind of trying to put in safety and some regulations that might.
Yeah, and I don't know if anyone's been able to do that or look at that. I think California was bad compared to other states as far as the bizarre packaging and things that are allowed. I was in Oregon in fellowship when recreational kind of started going live, and they put in some more rules about packaging and dose and maximum number of doses and what things were allowed to look like, and kind of plain white packaging with a label, and nothing that makes it look anything like a candy or food. So I don't know that anyone's tried to quantify things based on level of restrictiveness of state laws and then correlate that with cannabis exposures. And now everything is so leaky, meaning all the cannabis goes everywhere, and we live in just a different landscape of cannabis now.
Like any substance that has abuse potential. This is not different than any other substance that we prescribe for certain medical reasons, but adds to the overall exposures, unintended consequences.
Dr. Carlson, do you mind if I ask a quick question to
Sure.
Dr. Moss? With the Utah data, was there a breakdown according to the type of product, edible, flower? I don't know if I saw that breakdown in the slide, but you may have it as data.
Yeah, I have it. I could pull it up. It's pretty easy for me to do that, and I can show. I would suspect we'd be similar as far as like this national data slide that I showed here. I'd have to go break it down, but I assume it's going to be pretty close to something like this. This is adults over 50, but it's still, you can see even edibles are a big part there. There's going to be a lot of edible products, a little bit of flour, and then some amount of vape. And, this also includes people, teenagers who someone gives, they tried doing dabs for the first time and they, get sky high or whatever else. And so this includes a whole spectrum of things that are outside of what we might think about of people accidentally getting into someone's medical cannabis supply. But I would think edibles are probably represent the bulk of our exposures, similar to these other states and similar to all the other graphs where the edibles really have taken off as being the big problem. But I could definitely break it down and send it to you guys.
Yeah, thank you, Mike. I really appreciate your presentation as well. And clearly the exposure problem has to do with access, just number of products out there and in households, but also dosage. The higher the dose, the riskier the reaction. So it's contributing to the exposures. But so I think that's a good segue into the our dosage discussion.
Katie, before we fully enter into it, I agree. I think it was a good segue. And I think Matt, Dr. McGiff's comments actually were part of that segue in that, one of the great advantages of having the state program is that at least with those products, we have a fairly good understanding of what people are actually getting, or at least they do, hopefully. There's some control compared with the so-called black market or where people might not know what they're getting. And in fact, one of the stronger arguments for decriminalization or otherwise framed legalization for other purposes is that at least there's some level of control over potential toxicities for what people may or may not be getting. For those of you who weren't back around in the early 1970s, so it's going back 50 years, where there was another, there's a spike now, and it took 50 years for the last real spike in, quote, marijuana toxicities in emergency departments. That's when I was a graduate student in pharmacology at UC San Francisco. And of course, San Francisco was, the Bay Area was an area that was sort of ubiquitous. Marijuana and cannabis was pretty ubiquitous back then. But the UC San Francisco was sort of an entry point for people coming through the Haight-Ashbury Clinic. There was a clinic there that was largely committed towards dealing with people who were having bad drug experiences in one form or another, along with some other public health issues. And at that point in time, when basically there was just typical cannabis at that point was fairly low, comparatively speaking, low dose THC compared with, it was before strains were particularly developed with high dose or high percentages of THC. People who were marketing their cannabis products differentiated them by trying to convince people they get a better or a greater high or whatever. And so there was a lot of adulteration of cannabis back then, especially with things were pretty cheap like PCP, phencyclidine. There are other abbreviations, DMT, STP, all these other psychoactive adulterants. And they caused significant, not only anxiety and paranoia, but oftentimes psychosis. So I think we've improved upon that era by having far more controls. And so that's a positive, but there's a long, and I think, storied history of this, which is for anybody who's really interested in cannabis, either for in general or where it might have a place in the medical armamentarium. This history is, I think, important to at least have some some understanding of, and where we've made some actually real progress. So to Matt's point, it's a good place you ended at, Mike, which is what can we do to continue focusing on safety while we're also investigating efficacy in different conditions. So that is, I think, Katie, a good segue into the dose guideline discussion. And
Thanks, Perry.
and Sarah, did you want to start? Because I have a little bit of another sermon on the mount I want to give and actually bring something forward for actually a board vote when we get an opportunity. But I know you've been working on this, so I don't want to steal your thunder.
Yeah, so I just wanted to give an update on where we are with the dosage guidelines. As everybody remembers that Dr. Norris had recommended that we create easily digestible, short 5 bullet point emails for providers to give them information that we want them to know, just because of our documents being so long that we were worried that providers are not knowing where to find the information they need. As we were in the process of doing this, we determined that it was time to do a search of current dosage recommendations because our guidance document was 2 years old. And so we've gathered and reviewed and discussed the research that we found. And the next step is for us to create a crosswalk of that research and available data. And I'm currently working on that. It's not quite done yet. And then Dr. Norris, I just wanted to see if you had anything else to add to this before we go to Perry.
No, that's a good summary, and hopefully we'll come up with that sort of information for people. So it'll be great. Thanks.
And thank you so much, Jennifer, for participating in that. That's very much appreciated. And Sarah, of course, you as well. As you all know, this is one of my priorities, and I'm just curious, Jennifer, from your perspective, kind of what timeline you see. And I've said this before, we don't want perfection to be the enemy here.
About 3 to 6 months. I mean, just something in the next 6 months, something that we can,
Next month.
distribute. Yeah.
That sounds, that would be great.
That sounds reasonable for me.
So a 4-week timeline. Great. Perry, go ahead.
Yeah, well, first of all, Sarah and Jennifer, this is, I think, a really important foundational document that you're going to be creating, because there's been a lot of effort over the last several years to go through all the literature and want to acknowledge. I don't see her on the Dr. Heath. Is she? There you are,
She's
Lauren.
here. Yeah, Lauren's here.
There you are. Lauren's efforts also, as well as we've called upon other individuals with areas of expertise, such as Dr. Odell at the university with regards to cancer pain, and Misty Smith, and then others. And I think that it's a fair statement to state that at this point, even though there's a lot of data points that can be put together as a crosswalk, and again, an important foundational document, that there are certainly is a dearth of prospective dose-controlled studies that allow us to have a level of confidence, or the highest level of evidence, if you will, using those terminologies, as is typical in clinical pharmacology, to to assert a standard per se. So I think that at least for the immediate, and partially I'm responding to the environment where the legislators are really begging us for guidance, and it's largely Senator Vickers who's reached out to me over preceding months, Dr. Carlson in her role as chair over the last several 6 months, and we've provided various legislators, but filtering mostly through Senator Vickers. He's been sort of the leading edge of this, a bunch of documents, but generally the conclusion is that we just simply don't have a foundational literature in a typical approach to give a high degree of confidence to say specifically with any condition, other than a few sort of hints along the way. And so what I would like to suggest, because we've circulated this amongst the board repeatedly now over, I think probably over the last year on several occasions, as long as to our legislators, the consensus document that I think provides as reasonable and rational recommendations as exist. It's focused on chronic pain, but there's simply nothing that exists in literature that would differentiate sort of a titrated approach towards CBD and then THC. And we don't have enough information on any other cannabinoids to go forward with anything more structured, but especially with CBD and THC, to go forward with that as the lead document, which I think we should really live with now until there's more evidence or such the crosswalk comes out and suggests there might be some refinements and nuances that perhaps we might add to other conditions. But it's really focuses on safety with moving towards, hopefully, the aspiration is some efficacy in whatever condition the clinician patient is wishing to treat under the proviso of the Utah State program. So I want to actually, in meeting the needs and the demands of our legislature, who we serve on their behalf, to proceed with a vote by the board to at least approve the consensus document that you've all seen, and I can put it up on the screen again if you want to be reminded, that does allow for that and is easily summarized in a short table. But it's very straightforward. It doesn't contradict any other major evidence that's out there, and was rationally developed as a sort of a modified Delphi sort of approach with a full review of the literature. And there's nothing, I think, that we found, Lauren and Jennifer and the rest of us who have been involved in literature reviews, that would contradict this. So with that, Katie, I'd like to put forth, with your permission, the board, if we think that we're ready to move forward with this while we are waiting the more robust document that Lauren and Jennifer are producing as a foundational document.
I'm very interested. Yeah, I think it would be helpful if you did put that up, if that's possible, as part of this dosage discussion.
Sarah, if you have it ready, you can put it up, or you can let me share and I'll.
I just made you co-host if you'd like to share.
Okay, so let's see, let's see, where am I?
And just to kind of simplify what you said, what I'm hearing is Jennifer and Sarah Ponce are working on what will be a more definitive, although imperfect and still some uncertainty, but a document that's more robust, as you said. And you're talking about covering the time between now and when that is out for.
Yeah, and I'm not. Yeah, because Katie, the crosswalk will be very informative in terms of getting in front of everybody who wants it, everything that's out there, but it won't necessarily really inform a guidance or a recommendation document in terms of, clinicians on the front lines.
Practical, yes, yeah.
Make recommendations for the patient.
Yeah.
Sarah, I don't see share screen. There it is. There it came up. Okay. Share screen, consensus recommendations. Here we go. Can everybody see this now?
It looks like it's loading that. There we go.
Okay, so this is the document you all had access to and hopefully have read a million times over and are bored to death with it. But this came out, was it 2021? So it's now 2 years ago, and it was brand new and fresh when it first came out. There's nothing that's come out since that's specific, more specific than this. So my motion would be that we accept this as the guiding document for the CRRB to provide to legislature as well as to clinicians as a dosing guidance for both initiation and titration of cannabis products under the state program. And then that we can then summarize the results in a table that should be readily easy to do. And I would think, Lauren, in your role, that would be, with your abilities in this way, would be something simple to do. And the rest of us can help if you want, but it's not that complex an issue. So anyway, that's the motion. And I'm curious if there's a second and if there's discussion as well that would prohibit us from moving forward post haste to meet the needs of our legislature, who's
I've read through
chomping
this.
at the bit.
I'll second it. I've read through this document and I think it is the best we've got. It's up to date and it's pretty comprehensive and it's a good starting point. Obviously, things could change, but I'll second that motion.
So I think, just to be clear, I think what we got now is the opportunity to vote on approving this. Is that we have, I'm not exactly sure how to frame this. What's the vote now? Do we all in favor of approving?
Well, yeah. I don't know if there's any further discussion, Katie, of that before we go to a final vote. We do have the second,
Okay.
so we've
Dr.
cleared the.
Fine, could I just make a comment, Dr. Carlson, about the motion briefly?
Yeah.
Great. So I know that the for lack of a better term, the subcommittee is considering this as one of the studies that they're putting together, and in the more simple recommendations in a crosswalk. And my understanding, and maybe Sarah Pons can correct me, but that subcommittee, their plan was to create some simple guidelines based on some of the information in the crosswalk, right? And that the plan is to have some of those simple guidelines ready to review in 4 weeks, right? So rather than waiting for that, what the board is wanting to, on Perry's motion, is he is wanting the board to present this study as some general guidelines. And Perry, are you also wanting the board to create a simple summary of this original research study that summarizes what's in here?
Yeah, this is already sort of summarized, and so
Yeah,
Right.
exactly.
to do. And what I suspect, Rich, having
But it's
been
12 pages.
I mean, up to my eyebrows in this literature now for, I don't know, a long time.
Right.
I suspect that the crosswalk isn't going to vary too much from this. It'll be much more robust because it'll provide all the data points for which actually this modified Delphi approach was
Yeah.
already sort of created. There may be some nuanced changes. It'll be very interesting and exciting and to see if there are some variances in those recommendations. But I do suggest we plow forward with this, not just for expediency, but I think this has been out there for a long time and there's nothing to contradict it. There's just no reason we should be waiting. I think that it's just a rational way to proceed. And then we'll see what the crosswalk, if it comes out in 4 weeks, great. If it takes 4 months, that's fine too, because we're no longer feeling this urgency.
Right. Do you mind if I ask Sarah Ponce to share some of her thoughts about this particular literature document? I know we've had some discussions about the many sources of literature that we've taken a look at on this topic, and there could be some things that are not introduced in this particular in these consensus recommendations that we should consider. Dr. Carlson, if you're okay, I'm going to call on Sarah Ponce to share some of her thoughts about some things just to consider.
Yeah, but I just want to clarify, I think, Rich, you said this is a 12-page document, and I don't think that Perry or the kind of vote on the floor is to share this actual document. But I mean, I believe there are 2 diagrams within the document. You could scroll
Okay.
down, Perry. I mean, that are fairly simple, and may be a substitute. At least that's how I'm
Okay.
hearing it. So I don't think Perry's, correct me if I'm wrong, is not saying we send out this 12-page article.
Yeah,
It's-
I'm just,
We're using the content, which has
Great.
already been summarized into diagrams in this article.
Yeah, so we've got a couple of tables and we could put some verbiage to them. But yeah, it's already, the work's basically already been done. So I don't know, I just see no point in belaboring this to the frustration of the legislators who really, want us to be responsive to their asks.
Now, remind me again, in this document, the dosing that they're recommending, are they talking about specific forms?
Yeah, Perry, scroll down, could you, if you go to page 5 and 6. Oh, you're on page 6, sorry, I have it pulled up on my, maybe back up to page 5. Is that, show Sarah what you're talking about.
Yeah, so
And
this is, and Sarah, so this, you're right, this is only relevant to any form of edible, not vaped and not,
Sure.
and those are some of the nuances that will come out. But if you remember what we've already garnered is the majority of, there's, gosh, I don't have those slides up, but a lot of what is being recommended and what is already being dispensed is in formulations that would adhere to this. So we may as well go ahead while we've got something, rather than continue. This is one of those, the enemy of the good is better or the perfect. It seems like we've just been treading water for a while. And I was sort of thinking about this over the last couple of months while we were on hiatus and thinking, we really could have and should have provided this to the legislature at their interim session when they were pondering these things and demanding some responsiveness. And I think what happens, and this is more background discussion, not for scientific purposes, but for, I guess, political and good relations, is that, if we don't meet their needs, that we either get discounted or they just do things autonomously, which are not then very well informed. And that's our whole purpose, is to be objective and provide them with this sort of information. So, and to synthesize it for them. They're not scientists, they're not clinicians. Probably most of them have very little experience with cannabis in one way or another. So anyway, that's a more of a, I didn't really want to bring up all that sort of stuff for this, but there you have it.
Yeah,
right,
no, I would
also,
love to hear from Sarah and Jennifer to see where, where their work kind of aligns with this.
So
Go ahead,
sorry. Okay. My goal was kind of to give just kind of a general dosing and not be too specific on condition, but then to also create, pull from other sources like this that do have specific conditions tied to their dosing, if it's different, and have that as a separate guidance document or guidance email or a link within the email we send out so they can do that additionally. But what were you going to say, Jennifer?
Oh, I think this is great.
Okay.
I don't know that I'm familiar with this particular article since I'm still relatively new to all of this. And my only concern with it is they want you, this recommends, as most people would, starting the CBD predominant, and is that even available in our pharmacies? So, if you're going to get to CBD of 40 before you add THC, can people even purchase that? And
And I'm not sure if it says the CBD predominant, if they have a definition for that in the literature.
But that's sort of the point, Jennifer, because we
Yes.
recognize that there's a big disconnect between what the science and the evidence and what the board is trying to provide and what the legislature wants to do is give responsible the responsible, program for its constituents and what's, potentially available for patients. And Matt McGiff has spoken about this repeatedly, and I sympathize with that as we look for things for our patients. So this is a good starting point, and sometimes you just have to start,
And just if I can make a comment, if we think about the big vision of, in the end, where do we want to be with the dosing recommendations? And Sarah, I think, made a good point of saying we'll have some general dosing recommendations that will be based upon a lot of the concepts and the crosswalk that Sarah's putting together for the board to take a look at, right, Sarah? So the very general dosing guidelines. And then there's something more specific for edibles that this consensus document would be geared toward, correct, Dr. Fine? Because this is only focused on edibles, right?
The conclusion of every single review we've done has been essentially start low, go slow, especially for more vulnerable populations, elderly, younger, etc.
Stay low.
And then titrate accordingly, but we need to put numbers to it. That doesn't really help. And so this at least is a starting point for that, starting with edibles. If you, it's a little more difficult to ascertain for flowers and buds and for vaping exactly what a patient is getting, depending upon what you inhale and how much you hold it. I mean, there's a lot of variables, but at least we can give our clinicians out there some basic numbers, because this is what doctors, PAs, nurse practitioners are used to seeing is specific doses for a different formulation.
Yeah.
And I think we can clarify that. I mean, this is an ongoing discussion with providers who are wanting to try this with their patients. So we can clarify that we're starting with what is a little better established than whole plant. And so this is specifically addressing edible dosages. And I'd love to circle back, Jennifer, and just give you a chance. I saw your head nodding, but I think that whether I'm in the category of trying to stay within our lane, and this is our lane. What's available on the shelves and what formulations are, sold more often in what dosage, that's not in our lane. And so I feel like this is a team effort among many parties and stakeholders in Utah, starting with the patients, in my opinion. And so this information is really important, even if we have to qualify it as this is the beginning, and this maybe doesn't apply nicely to other formulations, but this is a starting point.
And just one thought is also we can prioritize focusing on this slice of a recommendation for edibles and prioritize that higher than crosswalk in order to get it done. And that may be helpful, Sarah, to you and Lauren as you put together, how exactly we put things forth, right?
Yeah, pulling recommendations from one source would be a lot faster than the crosswalk.
Right.
Yeah.
And then
and again,
on,
just to clarify,
some of the others.
To clarify, Sarah, I've heard you say what you are working on is dosages that apply, a variety of dosages for a variety of conditions.
Yeah, these are just general dosing
Yeah.
recommendations.
And that's to me, that's again, I think the literature doesn't necessarily support a big difference in dosing based on the condition. It has to do with the patient, what's their tolerance, what's their age, what's their co-occurring condition. So, and Jennifer, what's your perspective on that? Like how worth our time is it to look at dosage guidelines that might not be general? And what's the value in trying to come up with dosages for the variety of conditions as opposed to just general guidelines?
I think general guidelines is top priority, just getting out
Okay.
basic information and in digestible amounts
Yeah.
for providers. Yeah. And to
All right.
patients. I mean, you could actually give a patient this graph. I mean, you could give them this and they could walk away with it and have an idea of what they ought to be trying to do, which I think is more than is available to them right now.
Yes, I
And
agree.
Dr. Carlson, just to draw your attention, Dr. Moss does have a comment, it looks like.
Oh, sorry. Yeah, go ahead, Mike.
I was just gonna, the legislative session starts next week. And so is there a time crunch to provide something to the legislature like right now? And we need to have something fast, in which case we say, here this is, or does this require a vote? Or do we need the other work and have that document? I don't know, it would be what's timely and what's most helpful for the legislature right now, just from a practical standpoint.
I think
Yes.
that's a good point. And I'd say now last month, the month before would have been better because they go in with some ideas already. But Mike, yes, I would say now is what we need. And we happen to have this. It's not perfect and it's not going to compete with Sarah and Jennifer's work for what might come out later after the legislative season's over. But I am of the, my perspective is yes, we need something now and here it is. And
Right.
can we vote on approving it as our recommendations for the time being? And it looks like, yeah, okay. So I don't know what others think and if that means we can move forward with a vote.
Dr. Fine, I just wanted to clarify, are you recommending, they have different protocols in there for different populations, like the one that we were just showing on the screen, that's one option for starting. And then they have another one that they call a rapid protocol, starting with 1-to-1 CBD and THC. I just wanted to clarify, are you recommending like the multiple approaches that they included in this article, or?
It's a good question. I'm not sure what the value is in terms of our program, what a rapid titration was. There's nothing is defined as sort of an emergent. It's not like treating an acute asthma attack, where you have to or heart failure or something where there's sort of an emergency or an urgent need for rapid titration. We could do both. That's why Lauren, I deferred to you a little bit to sort of see what you could construct around this in terms of very easy bite-sized ways. I would certainly start with a more general approach rather than a more rapid titration, because I don't see that there's an urgent medical need. We're treating chronic conditions and chronic progressive conditions. There is the acute pain condition that's been added, it was added a year ago. I'm not sure where in the world that stands as far as anything that applies within the right now, but that's generally not the first line for acute pain management. So anyway, I would suggest not including that yet, but if you think
If you have an idea, that might be helpful, Perry, if you want to take like kind of write an outline as to what you're envisioning this to be, that might be helpful. Since I think you're more familiar with this.
Well, I'll certainly, I'll draft a table. It'll be very similar to what you see in there.
Yeah, I think that would be helpful.
To the point that was made about the need is really for a general overarching guidance for the vast majority of clinicians taking care of the vast majority of patients under the program, what do they need to know and how can they be informed? Simply and without being overly reductionistic based upon best evidence. I think that's the way to proceed. And then, once the crosswalk comes out, we can refine. That'd be great. I'll be happy to do that.
Thank you.
I don't want to usurp Lauren's role. I know that's sort of, I'm always
Yeah.
happy to do it. The bidding of
She's
whatever.
on a project right now, so it may be hard to get that done.
Okay, yeah, I'll within the next few days, I will certainly bring that forward. And so if you have confidence and want to, I will not ad lib. I will simply reformat.
Okay.
So that if we want to proceed with a vote, I think we can do that with confidence.
Great, thank you.
Thank you, Perry, for that.
So there's
So
been a
we're-
motion and a second, right? I believe.
So we can do the vote now.
Mhm.
So all in favor, raise your hand or say aye. Aye.
Aye.
All opposed, raise your hand or say opposed. Okay. Great, thank you. We got a little behind on the agenda, but that was very worthwhile. We were going to have a product list discussion and so Matt and Sarah, do you want to take that away?
I don't really have too much to add, just that I wanted to say that when we started this project, we identified that we need to do some standardization and cleanup of our database so that we can get everything in a format where we're able to list them in groups. So that's kind of where we are with that, is hopefully to reorganize our database. And then Matt, do you have anything else you want to add about this project or thoughts?
Well, I could talk for 5 or 50 minutes on that. I think a formulary or a product list is really essential.
Yeah.
Formularies came into being for 3 purposes: to encourage the use of safe, effective, and affordable medications. And I think those are 3 of our goals: safety, efficacy, or I would add consistency. For treating patients, we need consistency. And then affordability. Every meeting we have patients publicly comment about affordability, and formularies tend to promote affordability. And so I think we need that for a host of reasons, which I don't need to go into. But like Sarah said, we need some categories. Again, I have another car analogy. When you go to buy a car or rent a car, you choose an economy or a compact or a mid-size sedan or a full-size sedan, or you have an SUV or you have a truck, or multiple categories within those. And we need some sort of way of communicating categorically products and to give someone an idea. And products can compete within those categories based off what they offer, but we need some categorical way of communicating these things, kind of like a car industry or any other industry. So a formulary or product list would offer that. And just like the car industry, a lot of the industry comes up with it. It's not like they need to be mandated. They recognize the need and they compete with each other, but they want these categories so that they can do so. And so it's not like it's an opposition to the industry. It's really in their favor as well. So I think we can come up with some sort of approach mutually beneficial to move this work ahead. So with that, I'll finish with that discussion on the necessity of a product list and a published product list.
Thank you, Matt. And this is important because this took up some of our meeting time early on, and we had Sarah and now I'm forgetting.
Jesse,
sorry. Present or kind of dig through, get into the weeds, and they found right off the bat a big obstacle to their effort. And so I think we want to put that back on the agenda. We'll put this on future agendas so that we can keep this going and keep this fresh in our mind. Because like dosage, I agree with you, Matt. This is a priority.
And can I make a quick comment about that, Dr. Carlson? So there's a few stakeholders that we will work with as we do this. One critical one is the Utah Department of Agriculture and Food and the licensed processors and the medical cannabis pharmacies, and also I think pharmacists and providers, because it sounds easy to say we can just categorize them, and it should be easy, but different companies have different ideas about how to categorize, right? And they get creative as naturally they're a business, and so they want to be creative about how they talk about their products. And what we can do is work as regulators and providers to guide that a little bit more than we have in the past. And it's critical that we do that as we prepare to make some changes to the model of our software in the future, where we want it to be able to be more usable and understandable, so everybody's on the same page with a uniform category of information that is collected from the very beginning. So,
and I would say, again, I think this board is limited. We're in a lane that can make recommendations. We're not regulators. So I see the formulary possibly as leading us to a similar place, making a recommendation that we need a formulary for all of the reasons that Mike or that Matt has spoken about and others.
Agreed. What
people do with that recommendation, it's out of our control. So again, I'd like to focus our efforts on what is within our lane based on the research that we've done and the expertise that we've brought in and the expertise that we have on the board.
Yeah. And if we're done with this agenda item, there's something related to that on the legislative update.
Right, go for it. Let's try to keep moving forward.
Yeah. So many of you are familiar with HB 72 that has been made public. It's the Medical Cannabis Governance Revisions Bill. It's sponsored by Representative Brooks and Senator Vickers. And that was approved by the Health and Human Services Interim Committee back in November. That moves oversight and regulation of medical cannabis pharmacies and couriers from the Utah Department of Health and Human Services over to the Utah Department of Agriculture and Food. And GHHS under that legislation will continue to register the qualified medical providers and the pharmacy medical providers, the pharmacists that work at the pharmacies will continue to register those. But Department of Agriculture and Food will oversee the facilities if that, all the facilities, including the pharmacies, if that bill passes. And one other element of this bill is the creation of a medical cannabis policy advisory board. And GHHS would provide administrative support to that board. And it creates 9 members. And GHHS would appoint 5 members of the board, and UDAF would appoint 4 members of the board. And it has representatives from the industry and from patient advocates. And there is a board member position that is designated for a medical research professional. And so if the bill passes, we would be, as a department, selecting a medical research professional to sit on that board. And I would expect that a topic that could come up at those future board meetings would be some of the same topics that have been coming up during this, the dosing guideline, the need for those, and also the product list as well. And that will do it in a setting where we have representatives from the industry and from patients and from providers in a public meeting at the same table, talking about recommendations they would like to make to Department of Agriculture and Food and to Health about those topics. And so I feel like that will be a great setting if this bill passes for that discussion to happen and for us to ensure that we then take action on some of those guidelines that they would be voting on. So that's HB 72. As a reminder, the legislative session starts next week. And so you can you can actually set up an account with the Utah Legislature's website where you get informed about how different bills are progressing through the legislative session. And so you can keep yourself informed if you choose to on that.
Rich, do you think you could you, is there someone in the department that could keep themselves informed and then let the board members know?
Oh, sure. Yeah, absolutely. That's
Okay, that'd be great. Thanks.
And so, yeah, I'll have one of our staff members keep the board informed. There will likely be a committee meeting where there's an agenda item that's dedicated to HB 72 and other bills. There's other legislation, obviously, that's possible that could be considered. And yeah, so that's where that's the legislative update. Also, controlled substance database integration of medical cannabis products. So several months ago, we incorporated the medical cannabis card verification capability into the controlled substance database. And so any provider can verify if their patient has a active medical cannabis card in the controlled substance database. But there's additional work that must be done before the database is modified to include information about particular medical cannabis products purchased by a medical cannabis card holder. And right now we're evaluating with thoughtful how other states have integrated medical cannabis product purchase history into the controlled substance database. We're looking at the categories, how they separate things to best inform a prescriber about that particular product that's purchased by their patient. And once that evaluation is complete, we'll work with the Department of Agriculture and Food and licensed processors on ensuring appropriate data is collected at the processor level. It's similar to the what we need to do in order to take action on the product list. We need to get down to that processor level data and ensure that we're gathering that information and that it's easily understandable with some guidance to prescribers. So that is the update on that topic. And then University of Utah, so we're in the final phase of finalizing our contract with researchers at the U of U, and their research proposal will gather information about experiences of patients using cannabis in the state's medical program. So that is moving forward. It's taken a lot longer for us to finalize this contract, but we're very close to that. And I thought for purposes of just sharing with the board some 2022 statistics, the number of medical cannabis card holders increased by 45% during the past year, from 42,600 in January of 2022 to about 63,000 in December 2022, by the end of December. So there was dramatic growth. Obviously, also the total number of QMPs participating in our program increased by 6%, from 845 to 895 in December. And so this month will likely reach that 900 mark. Also, medical cannabis pharmacies made 15,100 deliveries to patients living in rural counties throughout the state. That's we did the numbers, and that's a 462% increase from 2021, and how many were being done in 2021. So a lot more home deliveries happening in rural areas. So those are just a few of the statistics from the past year that I thought the board may find interesting, as we've, of course, reached the new year now, and we can look back and gather some of that data. And that's all.
Great. Any questions about that? I'm hoping next meeting we'll have more time to talk about the database and the integration, and I think it would be great to kind of maybe even look at what's actually there. I mean, I know that it's a website we can't just jump on, but I think that's a really important part of this program as well, and with the formulary and with some dosage recommendations becoming standardized, that feature will help a lot of providers feel more confident in being able to make safe recommendations and know what's going on with their patients. Okay, we did get through everything. Let's turn this back to board members to circle back with questions or comments on anything that we've been discussing. We're such a quiet bunch. Okay, I think, again, I can't see everyone, all the board members on the screen, but I'm getting the sense we have no questions. So let's move to the public comment period. And I'm just going to remind everyone 2 minutes, and we will have to cut you off after 2 minutes if it goes past 2 minutes. Raise your hand. I'm able to see 1 or 2 hands now. Raise your hand if you have a comment. Please keep your comments relevant to what we've been discussing and what the board is capable of responding to. And just a reminder, state your complete name, identify what your affiliation is, or whether you're employed or affiliated with a grower, processor, manufacturer, marketer, seller of hemp, cannabis, or cannabinoid product, or an organization that lobbies for or on behalf of such. And then we will hold off until we get to all the comments before responding as a board. So thank you very much.
Okay, we'll start with Zach Newell King, please.
Hey guys, can you hear me?
Yes.
I just wanted to say that the biggest thing I heard for this whole thing was how much education is the key. Prohibition happened without our permission, and the biggest thing to focus on is that cannabis has no LD50 that's been established, whereas aspirin and Ritalin and many other dangerous drugs are in our homes. And I, for one, was prescribed Ritalin at 7 when cannabis was much more safe, and I had a horrible time with those other drugs. The biggest thing that we can focus on is that cannabis has 0 deaths total from natural cannabis. It's our responsibility to get these synthetics out of our system and out of just everything that we have to face as a patient. It's all about knowing what's the purity, how was it grown, was it organic? I highly suggest the board focus on clean organic medicine and not these formularies that are focused on other experiences, when the reality is our endocannabinoid systems are so complex that it's up to the patient to truly understand what they're going through, and to give them a guidance is key. I think that's great what you guys are saying about that. But to take away any type of access we have to medicine would be extremely detrimental. Access to medicine is important for those children as well. When I was 13, I had a paintball injury detached my retina. They prescribed opioids and steroids and other things, and I had horrible reactions with those, whereas I actually utilized cannabis, and I've been utilizing it for over 25 years. And there are many patients like me that have used it for years and years without negative reactions, without these horrible things. My wife died from Ambien 10 years ago. I've lost many friends from opioid reactions, and even when they had the legal prescription and they took their prescribed dose, cannabis is not anywhere near that dangerous. And I think we need to focus on the safety and the access to our 4 ounces of flour and our 20 grams of
thank you.
concentrate, and stop the database. Please don't put us on that. Thank you.
And just a reminder, state your affiliation or state whether you have no affiliation, just for future comments.
Okay, we'll move to Dr. Mark Viner, please.
I'm actually a patient advocate with Truth, and many of us are patients that are struggling. So please don't just take away our program or our ability to survive. Thank you.
Thank you, Zach. Okay, Dr. Mark Viner, please. Dr. Viner, we can't hear you if you're speaking. All right, we will move to Zachary.
Hello, hold
Chase.
on.
Oh, okay.
Can you hear me?
Yes,
Okay,
now we
my
can.
name. All right, Mark Viner, no affiliation, psychiatrist in Nevada. The CBD, I enjoyed the talk, but there is sedation and depression, infection, liver, kidney issues, immunosuppression, and withdrawal, pro-inflammatory issues. So it's not totally safe. We got to be careful. So the database is important if you're on other sedatives, even with CBD. The dosing, for dosing, I like Nevada's consumption lounge cutoffs for single use upper limits. The article's nice, but 40 milligrams of THC in an old patient with chronic pain is actually kind of dangerous. And then, of course, if it's CBD isolate, there are hundreds of milligrams. So I like the foreign article, but it doesn't take into account some practical issues. So we'd have to be cautious if you want to approve that. I'm not comfortable giving 40 milligrams of edible THC to an 80-year-old in chronic pain. That's actually, okay. So, and then finally, product list is important because it should include quick access to the certificate of authenticity. So you could do your inorganic and organic analysis with the patient while you're treating them in real time. Thank you. Have a good day.
Thank you. Okay, now we'll move to Zachary Chase, please.
Hey, how's it going? I'm Zachary Chase. I am affiliated with Truth, and I think that was it, right?
Right.
Anyway, thank you for letting me chat or speak for a second. I saw my mom's best friend go through cancer recently, and she lost her best friend to cancer. And as she was journeying through this, she couldn't really get access to the medicine she needed here in Utah. And I watched her die, and how it wrecked my mom. And part of this, I love how everybody's like talking about how we can keep it safe away from the kids and all that. It's showing the stats. It's awesome. And we need to do that. It can't be looking like the energy drinks here in Utah, how they look like a bunch of whatever, exactly what we're trying to avoid with cannabis. That should be illegal here in Utah too. But anyway, the point is, with the little time I have, she had to go out of state and figure out a way to juice the cannabis. And it would have been nice if she didn't have to travel while she was, had her cancer. And because she couldn't consume it, smoking it. She could have done an enema, but that's, I don't think, allowed here. And so there's a lot of restrictions and things that every need is going to be different. But Nevada does have a lot of cool things with 2.5 milligrams. The little vape pens that, or when you hit the vape pen, it lets out a certain amount instead of like a micro dose. And so we got to get creative but also be expansive and keep the program expanding instead of limiting it, because certain patients are being left out. And it's just, imagine that, having to travel during that time. And I didn't have all the options here, and I didn't want to go out of state to help her and then get in trouble. And so anyway, that's just something that I want to share. Thank you.
All right, thank you for that. Next, we'll have Christine Stenquist.
Thank you. Hello, my name is Christine Stenquist. I'm the president and founder of Truce. We're a local patient organization focused on patient advocacy, and you have several of our patients advocating in here today. One of the points I wanted to bring up about the dosing guidelines that you guys are recommending, the problem we have in our state is CBD is not allowed in our pharmacies, and allowing those products means you're going to have to sort of recodify the law and the rules that we have in place. So it sounds like you guys are talking about a different program than what we actually have. So I want to just draw attention to that point. You need to work with the MJ Freeway. Maybe Rich has something in the pipe that I don't know about, but that's one of the points I wanted to make. Another point I wanted to draw attention to was the fact that Dr. Perry Fine made a motion at the last meeting that he wanted to find out within a day or two the legal authority to the rule changes. Catherine said that she agreed and would work with Oborn to find out that information from the Attorney General's office. And I've noticed with this board, we don't do follow-ups to meetings before. And so as the patient advocacy group, I'd like to know what is the position and what's going to happen with these synthetics that are in our program currently. That's my question. Thank you.
Thank you. Okay, now we have somebody named Angel's MacBook. You'll state your name.
Yeah, my name is Angel Perez, and I'm affiliated with Block, and I'm also a patient. Block Pharmacy in South Jordan.
Great, go ahead.
Yeah, I just wanted to also follow up that we would hope to have some follow-ups on these meetings of questions that did go unanswered, or any of the past conversations that didn't get fully answered, and including sometimes when like products are removed from our pharmacies due to the interpretation of the law. One was like seltzers. We didn't get a clear direction as to why that was removed. I did see that there was a update or amendment to that now as of December 1st, that under 30 milliliters, tinctures are allowed, but over that milliliter limit, seltzers aren't allowed. But sometimes seltzers, will carry 8 to 10 milligrams of THC, as opposed to some of those tinctures that'll carry 100 to 500 milligrams. So the interpretation on the, the law side with the DHHS, I do see that there's some sort of disconnection, as well as the point of need that the patients are getting at our pharmacy. It seems like we get the most of the conversation along with the doctors of what the patient is getting relief from. And, I've started to build my own product guide. I started off with flowers, and I got about 133 so far with all the terpenes from those providers. I've done the terpenes from the COAs that I've gotten, but I've had to do that all on my own personal accord, because that's just something that the DHHS and the providers don't give us. It's something that we got to do on our own. And if the Department of Agriculture is testing these on a monthly basis, they should be able to provide us at least with some sort of data for the strains that they're testing, whether they're terpenes. But eventually it gets put on either the pharmacy or the producer to ask for those things. And I think we could build a lot better of a full circle conversation with the pharmacy, the DHHS, coalition groups, and lawmakers, those senators that are trying to implement some of those laws, especially.
Okay, thank you. That's 2 minutes. I'm sorry.
Yeah.
Okay, that's all the raised hands that I see. Is there anybody else that would like to comment?
Can I mention one thing? I know my time's up. It's just, there's very few products left in a lot of the dispensaries I've been going to with my mom in the last week. And this is a problem because if we don't have access to our medicine, where do people go? Deseret Wellness, cannabis. It's like, so anyway, I'm done. But if we can't find our products in the dispensaries, the ones we count on to help us sleep, the ones we count on to be our medication, where do we go? Sorry, I'm done. Thank you.
Thank you.
Dr. Carlson, would you mind if I just responded to a few of the items that came up? If there's no other comments.
Go ahead. Go ahead.
Great. So a few questions came up. There was a concern about there not being follow-up on specifically some of the items that came up. I know a topic that came up during a previous meeting was the Department of Health and Human Services and the Department of Agriculture and Foods interpretation of the statute relating to synthetic cannabinoids. And we, just so everybody knows, we did provide some information via email, and we have a small group discussion with some of the board members, not a quorum of the board members, but we were able to share with some of the board members our legal interpretation of the law. And I can share some of that right now. It's we were able to consult with our Assistant Attorney General on the topic, and one thing that's critical is that there is a I'm just going through the statute right now. And the authority to regulate the contents of medical cannabis that rests with the Utah Department of Agriculture and Food, but they request input from the Department of Health and Human Services on several items. And so we have provided them input regarding some of the things that have come up. And one of the keys is that there is the term adulterant, and that term of adulterant is defined in Utah law as any poisonous or deleterious substance in a quantity that may be injurious to health, including pesticides, heavy metal solvents, microbial life, toxins, or foreign matter. So what agriculture came to us with is there evidence, is this question, is there evidence that there are cannabinoids that are poisonous? And if there is, we want to gather that evidence. And we, of course, there haven't been a lot of studies on these specific synthetic cannabinoids that were coming up as byproducts on some of the products that were being processed. And so while there is not evidence that they are poisonous, there's also not evidence that they are of a particular medicinal benefit, right? Now, the Utah law is written in such a way that currently that it requires that in order to limit or ban the substance, that we would that there would need to be evidence of it being poisonous as an adulterant. And there are other substances that are banned because they are poisonous, and we do have information about that. But we don't have the reliable evidence, the scientific studies that have been shown that there are some of these other cannabinoids that are poisonous. So we know that lawmakers are interested in taking action during the 2023 legislative session to give the Utah Department of Agriculture and Food more authority to take action on those cases. And I know that lawmakers have been getting a lot of input from the industry and from patient advocates on this issue. And we have provided them input on this issue as well. And the Utah Department of Agriculture and Food has. And so the power lies in lawmakers to be able to take action to give the express authority that if there really isn't any evidence in a study of a particular cannabinoid being harmful, that Department of Agriculture and Food could still take action to ban or limit that substance. And keep in mind that a ban is different from a limit. And so it could be that lawmakers in the end decide to do a ban, or they could decide to give Department of Agriculture and Food the ability to limit. And so it would be required to be under a certain amount in testing. One advantage that Utah has is that we do have a reference lab at our Utah Department of Agriculture and Food that keeps the independent testing laboratory in Utah in check and ensures that the testing that's done is accurate. Other states don't have that advantage, and they rely on private companies to do the testing. And there are states that look at Utah and say, hey, we want a reference lab like the Department of Agriculture and Food in Utah has, so they can ensure that there is some checks on the actual COAs that are produced by the independent testing laboratory. So anyway, that gives you a general idea of the Department of Health and Human Services interpretation of the law. And we know that that patient advocates have contacted lawmakers. We encourage you to continue to do that and to continue to share what some of your concerns are with certain things in the program, and lawmakers can take those actions that would give Department of Agriculture and Food and the Department of Health and Human Services the authority to do certain things. So that gets back to that issue. One other issue that came up, I believe, was a concern about the prohibition on the beverages that were 30 milliliter or more, and that is a part of legislation that passed during the last legislative session, and so medical cannabis pharmacies have time to sell their inventory of those. And if you have a question about why lawmakers decided to take that action, you're welcome to reach out to lawmakers and ask them. That was something that lawmakers consulted with the Department of Health and Human Services about, but it wasn't our call to make, that was their call. And so that gets back to that item. Also, I want to emphasize that if there's a case where a particular individual that purchased a product is unable to obtain a certificate of analysis on a specific product, to reach out to the Utah Department of Agriculture and Food and file a complaint. Those certificates of analysis should be available upon request. I know there's some pharmacies that make those available, I believe on their websites. You can click and get access immediately to that certificate of analysis. And so you can see the detail about what the product contains. So some pharmacies go to that link. Others, they don't have a link on their website, but upon request, if you're having problems getting a copy of that certificate of analysis, then you'd be welcome to contact Department of Agriculture and Food, and they can follow up with that and make sure you get a copy of that so you could see that. I think that addresses a lot of the items that came up that were relevant. So anyway, I think that I'll just end there.
We do have
Thanks for the
one
time.
other public comment. Is that okay to allow
Okay.
Blake to speak? Go ahead, Blake.
Okay, thank you. My name is Blake Smith. I'm the CEO and Chief Science Officer for Zion Pharmaceuticals. A quick comment to patient availability for access to medication. We have vault full. We have vaults literally full of products. The reality is pharmacies get to choose what they provide and what they don't provide. And so, when we talk about, I would find it highly dubious that the board actually knows what products are out and available and who produces what and all the different products that are not being sold in various locations. There's lots of products, just some pharmacies choose not to carry them. Secondly, I want to just make a comment, the definition of adulterants, you don't know if synthetics are adulterants, but we have no evidence to suggest they're not adulterants either. Lack of data does not equal safety. That's just a fact of the matter. And then I also am curious that the first study that's being done is a qualitative study by the University of Utah. It seems like it would make way more sense to do an ADME study, a DMPK, mechanism of action, something that actually is quantitative so that we can actually answer a lot of the discussion that was done today. In terms of dosing, in terms of all those things, those can all be answered by normal validation studies done for pharmaceuticals as a normal medicine procedure. And there are some companies that know how to do all those things. And so anyway, I would just make the comment that we should focus on quantitative studies and less qualitative studies. That's all. Thank you.
Quick response to that, Blake. I appreciate that. I would certainly, my personal view would be to support that fully. It's the legislature funds what the legislature funds. This is what they wanted funded. This is what the RFA went out, and the group that had the ability to do that. I guess Rich won that award. So boy, I'd certainly love to see more funding come through, focused on and identifying the need for methodologically sound research that you're describing. I also want to comment on my frustration, which I think I share with almost everybody who's spoken, with regards to the view that how irrational it is to me as a physician, clinician, scientist, et cetera, and public health advocate, that something has to be proven to be harmful rather than proven to be safe before it is allowed to be viewed as a quote, a part of a medical program. This completely contradicts the normative customs and practices in clinical pharmacology. But according to state law and interpreted by the Attorney General's office and council, that is not where things stand with us. I don't understand it. It doesn't make sense. But certainly those concerns that have been brought forward resonate. I also want to respond to the two Zachs, Zach 1 and Zach 2, if I might, that certainly our view in the CRRB board is not to be prohibitive. It is to elucidate what is safe and effective and what the literature and evidence out there demonstrates to be so, including a lot of, patient experience. And so certainly our efforts are meant to open that up rather than close it down. With regards to the synthetics again, I do view that as problematic. And yet we don't, we're not a regulatory body. So I know that this is sort of a place where people can air their views. What the board, including myself, speak to in these meetings is within the guardrails of what our legislative mandate is. We can't be everything to everyone. We have not been authorized to be a legislative or regulatory body in the way that you're suggesting we might like to be, any more so than we can regulate clean air requirements for the state of Utah, so we don't have to breathe poisonous air throughout every inversion that ever occurs. Boy, wouldn't it be lovely to have that authority, but we don't. I don't mind being a stalking horse, but I certainly do appreciate your frustration, and I think some of us feel the same way. Anyway, those are my responses to supplement what you've already heard. Thanks, Katie, for letting me speak.
Yeah, thank you for the responses. I think anyone else from the board want a chance to respond to what's been to some of the comments that were made. We have about 3 minutes.
And we do have one more hand raised as well, if not.
Yeah, I think we should probably give the board a chance to respond to what was already asked, if possible. Anyone else? Okay, maybe we have time for a 1-minute comment.
Go ahead, Kyle E.
Can you hear me okay?
Yes.
Okay, so it's more of just a suggestion.
Can you identify yourself?
Oh, yeah, sorry. I'm Kyle and I'm affiliated with Truth.
Thank you.
And this is, since I don't have much time, this is more of just a suggestion in regards to dosing guidelines. Those guidelines should be discussed, and that discussion should take place during the new patient consultation with the pharmacist. That conversation should be based on the patient's experience with cannabis. It should also be based on patient medical info, current medications, and importantly, product delivery. That's all I've got to say, so thank you.
Thank you for that suggestion. Okay, I think we are at the end. We need a formal motion to end the meeting.
Motion to adjourn.
I'll second.
Okay.
I'll make a motion.
Thanks, everyone.
Happy New Year, everyone.
Everybody. Take
Thank you
care.
all.